for EMS providers, this is one of those calls that strikes a little bit of fear because they're so rare.
I remember a call on the radio from the charge nurse, get a gurney outside. She's giving birth.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Here we are, Unit 2.
Part 2. Yep, took a little break, got some coffee.
Should we talk about all the things to click again, or do we just get into it?
Well, if you're listening to the podcast, you didn't stop listening because this is a continual thing.
I see. I'm glad you know what you're doing.
No, that's fine. But yeah, this is Unit 2. If you're watching this for CE credit, this is Unit 2, so you'll follow that. That's the separated one. But yeah, we talked about, you just got done listening to Unit 1, so we won't review too much. Now we're going to talk about some fun stuff. I don't know about fun stuff.
Yeah, it's
more detailed stuff.
As far as pregnancy goes, this is like you're landing the plane now, right? So this is the pregnancy-related emergencies. So we broke it up into 3 sections.
Yep.
Antepartum, intrapartum, and postpartum.
Or to speak EMS before, during, and after.
Good.
Put it in layman's
I
terms.
love that about you, Matt. You make things so much more simple.
That's because Matt has to make them simple so they make sense to Matt.
I think that's why people like you. Is like you make things, complicated topics, easy to understand.
Well, and I think that's what makes us good instructors. I know because I have to break it down to a super simple level so that I can understand it, right? Because that's just the way my brain works, right?
Yeah.
But a lot of people, I've always said, it's like Michael Jordan teaching you how to play basketball. So much of that came so natural to him. He doesn't understand how somebody can't move like he does. Or, a lot of doctors don't why can't you understand this concept? I just explained the pathophysiology. And I'm like, okay, dude, because my brain doesn't work like yours. I need to break it down to a 3rd grade level because I'm a fireman and I need to understand it and then build upon that, But all of our brains work different.
Well, I think that's my favorite part of teaching is those aha moments.
Oh,
that's
yeah,
what we
100%.
all love
as a teacher and a student.
And a student, right?
Yes. Yeah, when you're finally like, this isn't as complicated as I thought it was as a student. Yeah. And then on the giving end of that, when you're a teacher and you can visibly, that's one thing that I love about live teaching is that you can see when the light bulb, sometimes you can see when that light bulb goes off, or you can see when somebody's really struggling. If you're a good instructor and you're reading faces and you're like, I've lost them here. They're not with me. And then when hang on, let's pause. Let's not keep moving forward because I can tell some of you are lost. What's confusing you? And then you go back and then you're like, okay, well, let's talk about it. And then it's like, okay, that's a great feeling as a teacher.
And sometimes in the virtual environment, we have people contact us through the website to tell us about how they learn something that treated a patient. So if you're listening and you learn something
new,
impacted your patients, got to tell us.
Yeah. And I think, like I said in the first part, with OB patients, because we don't get a lot of these patients, it's crucial that we're constantly studying these type of patients.
Yeah.
Because, with a lot of patients, you're going to learn through experience because you're doing it every day.
Right.
But these are patients that are very rare. And so you really got to know what you're doing, and you're not going to get that through experience. You're going to have to get that through education. Yeah. So before, during, and after pregnancy.
Yeah, antepartum, before pregnancy, or before partition is what antepartum would be. But
is that Latin?
I think so.
Most of your memory.
Well, it's probably, I think so. I think it's Latin.
I don't know.
But so before pregnancy. So as you're approaching pregnancy, there are certain pregnancy-related emergencies that can occur.
That's right.
And the first one we're going to talk about is preeclampsia.
Yes.
So this that woman who's complaining of certain things that are associated with preeclampsia, with high blood pressure.
Yep.
So one of the, common complaints would be headache.
Blurred vision.
Yep. Visual disturbances, we would say.
Yep.
You can even have, let's call it visual scotoma, or sparkly lights.
Yep.
Blurry vision, those types of things can occur with the headache. And then they may complain subjectively of swelling, abdominal pain.
Typically like lower extremity swelling.
Correct. Right? Yeah, correct. Yeah. And it can be anywhere.
It can be, but that's the most common place that they're going to have pedal edema.
Correct. This dang planet with gravity, it's just
exactly.
causes all sorts of problems.
Exactly.
Did you know that gravity is the weakest force known to man?
The weakest force known to man.
Yeah, isn't that an interesting perspective?
Never thought about it.
It
is interesting.
It takes this giant rock we call Earth,
third rock from the sun,
to hold me down, right? Where I can still jump against its force.
Okay, yeah. Makes
But
sense.
it really is. Gravitational force is the weakest force known to man. It's a very weak force. It takes a tremendous amount of mass to create that force. It's weak. You know, you think about it, the force you generate with your quadriceps can lift you up against it, right? I mean, it's a very weak force.
For context, last night we had our Ace Christmas party.
We sure did.
And I did a little roast of Dr. Axene.
You did a roast.
And this is what we call Dr. Axene chasing a squirrel as we're talking about antepartum pregnant patients.
Gravity.
And all of a sudden we're talking about gravity. And I think I said, well, as a matter of fact, I have it right here on the phone.
Oh, no.
No, I'm not going to read the whole thing, but the one line that is applicable to exactly what we're saying is he's like a giant yellow lab that will knock you off your feet when he goes chasing a squirrel. But the good news is you're a yellow lab, and everybody loves yellow labs.
Well, see, the thing I like about it, though, is like it may have been better time to do it later. To
Last
talk
night in
about
the dinner?
gravity. No, talk about
Oh,
this.
yeah.
But I view them as a brain break, right? You're talking,
for sure.
you know, it's like a.
Oh, it's fun.
It's good to have a brain break.
Yes.
But
I just
every
don't
now
know
and
how
then-
you keep all this knowledge in your head. It's amazing.
I love you like a brother.
It's amazing to me.
No, we can't take ourselves too seriously.
Oh,
right?
no. I love the Harley picture with me and Haley Joel Osment and my cat.
Can you pull those up and show them? We should pull them up.
I don't have them.
Oh, I'll give it to you.
have them.
I'll
Yeah.
give it to you.
Yeah. Yeah. You give them to me and
Be
I'll
kind
put
of funny, actually.
Yes.
Anyway, so gravity actually, that's why we have that dependent edema. For somebody laying in bed, you actually have dependent edema along the whole backside.
Right.
That's
That's why blood pools and dead people.
Exactly.
On the backside. Yeah, same thing.
So gravity's pulling that blood down to the lower extremities.
Right.
And that edema is part of the diagnostic kind of picture of a person in preeclampsia.
Right.
Technically, the blood pressure, 140/90 or higher, is that number that really clues us in. But like we talked about in the lecture, you don't have to have high blood pressure to have preeclampsia. You want to really look for these signs and symptoms that we've been describing.
And two, don't forget of the power of asking questions, right?
Oh, yeah.
Ask your patient, have you had any issues with your blood pressure? Have you been diagnosed with preeclampsia? Has your doctor said anything? Talk to your patient and ask them these questions because that can take a lot of the mystery out. Oh, yeah, he said I need to be watching my blood pressure. Okay, now you've kind of confirmed that you've got this issue going on. Like, that's taking that whole approach of patient assessment. It's not just with your vitals. Talk to your patient. Ask them.
Right. It's okay to cheat. And get,
That's
and
not
get
cheating.
the
That's
answer.
being a good paramedic. That's being a
Exactly.
good clinician. Is using every bit of I tell my students all the time that being a paramedic is like being a medical detective, right? And so you don't just go in, right, as a detective if you're trying to solve a crime and just look at the clues.
Yeah.
That's just one part of it.
Yeah.
What else do? You bring people in and you investigate witnesses. You investigate potential suspects. You investigate or you talk to the victims, right? You get their side of the story. And you take all of the information, the clues that you see, whatever, the interviews that you did to paint a picture of what happened. It's exactly what you're doing as a paramedic or a physician.
That's right.
Right? And so one part of that is talking to your patient. Yeah. So anyway.
Yeah, my doctor and I, we've been working on this high blood pressure issue. He's concerned about me getting preeclampsia again.
Yes.
Yeah, every
Red
pregnancy
flag.
I have it. It's like,
Yes.
Wait a minute. Okay.
We just solved the problem. Yeah.
Right.
This is.
But don't anchor on it because it could be something else,
That's
right?
right,
But
yes.
keeping your mind up. But you're right, though.
Yes.
I mean, talk
well,
to your patient.
and if I have a preeclamptic patient, right? My next main goal is, are they going to go eclamptic? Because
Yes.
there's a pre in front of that.
Yep.
And obviously, if they go eclamptic, I'm preparing that this patient could very easily seize on me.
Correct.
And so I'm mentally preparing, okay, what do I need to have an IV access?
Yep.
I need to probably have my mag out and ready to go. What's my dose? Check all that. Have it ready to go. That way, if this patient starts seizing, I can
Yep.
do
And
my thing.
and it might not be a bad idea to give it even preemptively if your protocols will allow it, right?
Or even call your medical control if they don't allow that. Like our current protocols that I work under do not allow that. However, if I have I shouldn't say that. If their pressure's high enough, I can do that.
Yeah.
But call med control. Yeah, and ask permission. And you know what? You're a medical control doctor, right? I'm a paramedic. If I call you as one of your paramedics and say, "Hey, doc, I know this isn't in our protocols, but I've got a 28-year-old female. Blood pressure is 150/90. She's got blurred vision and an extreme headache. I'd like to give her 2 grams of mag so that she doesn't go eclamptic on me. Are you okay with that? What would you think?
Give 4.
Okay, there you go. Yeah, and so that's. But what would you think about me as a paramedic, or that paramedic that's calling you?
They're thinking.
Exactly.
You're thinking.
Exactly.
And it's like you're not just following a recipe book protocol, right?
Exactly.
You're thinking. You know what? I think I might need to do more.
Yes.
And go for it.
Yes.
You get somebody into seizures, your hand's going to be forced. Let's try to prevent it.
Yes.
And get them to where they need to go. Because the cure for this, if they do become eclamptic, which is the next thing we're going to talk about, which is basically everything we just said plus seizures, the MAG. Yeah. Follow your protocols, but given that MAG IV is going to be the first line treatment for it.
Yes, and if your protocols still have benzos as your first line treatment, just squirt it out the window and give the MAG. No, I'm just kidding. Don't do that.
That's right.
No, but I mean that's something to bring up because I've had this conversation. You've had this conversation with lots of people because I've worked with protocols that it was benzos first and then the MAG. Yeah. And we've had a lot of conversations over, give the MAG first. Yeah. But so maybe talk to your medical director, get their viewpoint on it. Certainly don't argue with the medical director, but.
Well, there could be other causes, though. We've talked about this before, too, right? There's overdoses, withdrawal, a subarachnoid hemorrhage, meningitis. Epilepsy, right. There could be a lot of things at play here. Yes. Again, pregnant women can get lots of other diseases too. Right?
All of the other diseases, yeah.
But with the headache, the edema, the abdominal pain, the whatever, all this stuff together, and then they start seizing with the high blood pressure. If it barks like a duck, isn't that what they say?
If it barks like a duck, then that's a duck.
Yeah, right. Whatever it is. So treating it.
Walks like a duck, quacks like a duck is probably a duck, yeah. Exactly.
Now you give the MAG, and the MAG doesn't work. Mm-hmm. Benzos may have a place, right?
Absolutely.
Follow your protocols, and even ketamine potentially for those seizures that are just not treated by other conventional therapies.
The important thing is to be thinking ahead. Yeah. Always, regardless of what your patient is, always be thinking, what could happen with this patient? Yeah. What should I be prepared for with this preeclamptic patient, with this pregnant patient, with this trauma patient, this cardiac patient? Mm-hmm. Putting the pads on somebody that's having a massive STEMI. Yeah. That's thinking ahead. Because
anytime you have a chest pain patient, we should be putting the pads on these patients. Yeah.
Yes.
Well, in this case, it actually reminds me of the case we had in the last hour. That preeclamptic that went into cardiac arrest. Mm-hmm. You got to think about these things and potential problems that could occur. Eclampsia is not a benign thing. No. It's life-threatening.
Yes.
So MAG first, benzos maybe.
Yep. Oxygen, like we said, always get them on oxygen. Yep.
No, that's good. So eclampsia, and don't forget those other things that can cause a presentation that may be similar to what you might think is a seizure from eclampsia. Yes. Don't forget those other causes. Even hypoglycemia is something we should think
please
about.
Always check a blood sugar. Yeah.
Now, one of the scariest or antepartum or what did you call it?
During, and after?
Before emergencies is an ectopic pregnancy. Mm. So this one's a little tricky because the patient may not know she's pregnant, right? Yes. That's usually how these will present.
Yes.
Yeah, I did miss my period. It is a little late.
For the last 9 months.
So you're going to have that pain. Yeah. It doesn't have to be one side or the other, but I guess maybe we should walk back and do this a little more sequentially, Matt.
Okay.
What is ectopic pregnancy?
Yeah, it's when the egg gets fertilized anywhere other than the uterus.
I like it that you said it that way.
Why? How was I supposed to?
Well, because you can actually because a lot of people will say it's a pregnancy in the fallopian tube.
Oh, okay.
But that's usually what it is.
Yes.
That's
adnexa, but it can be anywhere outside of the uterus. That is an ectopic pregnancy. It doesn't have to be the fallopian tube.
You can literally have a baby. Outside of the fallopian tube, outside of the uterus, in the abdominal cavity potentially. So
rare.
It's rare, very rare.
But typically an ectopic pregnancy is in the fallopian tubes. That's where it occurs.
And that's the most dangerous place to have it because of that fallopian artery there. Yes. And you get a pregnancy that develops in that confined space. You rupture that artery, you can bleed.
Lots of bleeding.
Yeah, lots of bleeding. And that's what makes an ectopic pregnancy dangerous. And so in the ER, and I think in the pre-hospital environment, any woman complaining of abdominal pain, of reproductive age, is pregnant until proven otherwise. We have to have that perspective.
Yep. Yeah. When I was working as a nurse, as pre-op, post-op, we do our nursing assessments and all that stuff beforehand. If you have not had a hysterectomy or you're not like 90 years old, you are getting a pregnancy test every time before you go into surgery.
Yeah.
No, if you're a 50-year-old female and you come in and you have not had a complete hysterectomy, you're getting a pregnancy test just because we're going to make double, triple sure that you are not pregnant.
I had a patient once that was talking to this gentleman and was going through surgical history with him. And he was actually, it was not a man. It was a woman, beard with obviously hormone replacement therapy and all that stuff. Did not look like a woman at all, but had the woman parts.
Yeah.
And it's important to know those things
It's
because
very important from a medical perspective. Absolutely.
It is.
it's
Because
a whole
those
different ballgame.
ovaries can twist,
Yes.
and the abdominal pain could be from the torsion. So don't forget to really ask a detailed question, and especially today is that
an ovarian torsion would be a little bit different than a testicular torsion. It'd be important to know the difference between the two, yes.
But in this day and age, though, too, there's more of the hormone replacement stuff happening on both ways, right?
Yes,
so getting a good history is crucial, I think. But with ectopic pregnancies, the danger here is hemorrhage.
Yes. Yes, and this usually happens in the first trimester, correct?
Yeah, first trimester.
So keep that in mind. But like you said, they may not know they're even pregnant, and then all of a sudden they're calling you for abdominal pain, which is a call we get all the time.
That's right.
How often do we have in our differential diagnosis? Oh, it's a 25-year-old abdominal pain. Oh, gosh, another poo-poo pain call.
Yeah.
Oh, hang on. This could be something else here.
Some of the sickest patients I've had have been ectopic pregnancies. I've shared some stories with you with just the blood in the belly, liters of blood in the belly after just a slow bleed over time, and that blood in the belly is extremely painful. Yep. So that abdominal exam is not a benign thing.
No.
You cannot send these people or let these people stay home. I mean, I guess legally you'd have to on a refusal if they're ANO4, GCS15.
And you better explain the risks that, hey, listen,
that's right.
You could be experiencing a life-threatening emergency.
Yep.
You could be bleeding into your stomach. You don't have to get all technical.
Yep.
You could be bleeding significantly into your stomach and you could die very
That's
quickly.
right. That is actually the key of the refusal, is making sure they understand those risks and benefits.
And I get into this discussion, I'll say, sometimes with guys about, well, they just don't want to go. And it's like, did you really try? Did you really try to get into? Did you really explain to them? Because I'll tell you what, I've been doing this over 20 years. I have never one time had somebody that I was really concerned with. Like, I mean, I've gone, okay, they fell, they're fine, there's nothing here. I get it. You don't want to go to the hospital. I get it, right? But then there's sometimes where you're like, oof, there's something's going on. You're whatever.
Yeah.
I have never one time had somebody where I sat down and had a heart-to-heart and said, listen, this is what I'm saying, 100% honesty. This is what I'm seeing on your EKG. This is what I'm seeing with your physical exam. This is what I think's going on with you. I'm telling you, you really need to come with me to the hospital. Please. Never had somebody be like, nope, not doing it. When you tell them, like, you could die. You could be bleeding in your stomach and you could die. Yeah. I've never had, I'm good. I'll just stay home. Now, I'm not saying it doesn't happen.
Yeah.
I'm saying that a lot of times do we really, convince our patients and communicate that to our patients. And if you do and they refuse, put that in your narrative.
Yep.
Sorry, we're getting
them.
off. Yes, in quotes in your narrative.
Most common med control call I get are refusals.
Yep.
And oftentimes it is. It's like, this EKG looks like it could be a STEMI. And they refuse.
Yep.
And they cannot. And I can talk till I turn blue, and it won't change their mind. But if they are ANO4, GCS15, and they understand and communicate the risks and benefits, like we've talked about in our lectures, they have the legal right, the autonomy to be able to make a decision, even if it seems medically unreasonable. Certain situations and exceptions we're not going to get into today.
Right. Yeah, interesting question for you.
Yeah.
You go on a pregnant female. No, she's pregnant. Okay. And she is in...
How many weeks?
Let's say she's 38 weeks pregnant. And she is having...
Non-ectopic pregnancy.
Non-ectopic, nope. But this is more of a legal question.
Oh, legal, go ahead.
Yeah. Tied into pregnancy. She wants to go to the hospital. She's having contractions, which she believes are contractions. They're several minutes apart, so nothing urgent, but she's having contractions. She wants to go to the hospital, but she's refusing to go to the hospital that you would like to transport her to. She wants to go to a hospital an hour away because that's where her OB is. How do you handle that as a paramedic?
An hour away?
Let's say an hour away. Yeah.
I know. We cannot.
She says, if you do not take me to my hospital with my doctor, I am not going with
Well,
you.
what's her complaint? I mean,
Abdominal pain and having contractions. She thinks she's about to give birth.
okay. So we have an imminent delivery.
Yes.
How many pregnancies has she had?
Let's say it's her second.
Second one. An hour away. Well,
30 minutes away, an hour away.
that's going to put her at risk. And put baby at risk. I think I would get her to the closest facility.
She's refusing. She's like, I will not go with you if you take me to
You have to be an
this
advocate for baby, not just mom.
hospital. Okay.
And but the maternal rights are different in different states. And if there's literally only one hospital here or another one an hour away.
Well, that's just where she wants to go because that's where her OB is. There's numerous other options, but she wants to go there because that's where she's had all of her prenatal care. And
Because see, I'm looking at our community now, and I've taken a unit out of service for 2 or plus hours to go drive out there. I think that's something else. We have to be a good steward of our resources. We're not a transport
But
service.
right
to
now,
take people
she's
an
your
hour
patient.
away.
She's your emergency.
Yeah.
Which is what we teach our paramedics. That don't worry about the next call. You're on this call, focused on this one.
If she's having if she's really going to have that baby like imminently, then I would not transport her. I would refuse.
She says, I'll just drive myself or have my mom drive me to where I want to go. I don't want to go with you. If you're going to take me over here, I'm not going.
Yeah.
This was a mega code question that I've had which I told him, I'm like, this is not a fair question for a new paramedic to ask.
Yeah.
But in my mind, what I would
This is a reasonable call I could get as a
100%.
med control.
So this is what I told our paramedics to do, and this is what the medical director and I talked about, is within your documentation, you have a refusal paperwork. It's not just a refusal of transport. You also have a refusal of destination, refusal of assessment. So I will tell my paramedics, before I leave, I understand, explain the risks to her.
Yep.
Okay, you understand the risks of being taken here. Yep. Okay, before I leave this house, you are going to sign that you are refusing to allow me to take you to the destination that I recommend.
The appropriate
and that you
facility.
want to go here, the appropriate facility. She signs that. Obviously, if nothing happens en route, we're covered. Yeah. If something were to happen en route, we're immediately diverting to the closest facility, right? But now I'm having her sign that before I leave the house. So if something bad does happen, I am covered. Legally I am covered that, hey, I try to do the right thing. I called med control, but I checked off refusal of recommended destination.
So
she signs the paperwork.
I'm assuming then that, see, I would, if I've got the med control call from you and I'm talking to her on the phone, I am going to, till I'm blue in the face, persuade her to go to the closest facility.
The scenario was she was adamantly refusing.
So absolutely refused.
Yes. To go with you. She said, I'll just have my mom take me where I want to go. And now you're wasting all this time on scene where you could have been around. Yeah. So it's like, she needs to be transported by ambulance. That's her safest bet, is that if something were to happen en route, you're there to help her. But you also have to legally be covered, right? So, like I said, recommended destination, have her sign, I'm refusing.
That's definitely a reasonable option.
And then you document the snot out of that, after the call. And like I said, if something were to happen en route, you immediately divert to the closest.
You have to consider the context of your whole healthcare delivery system too.
For sure.
I mean, if you're the only ambulance in your community,
there's a lot of things to consider. Yeah, a lot of factors.
It's interesting.
But I mean, how is that any different than what if she was allowing you to go and the closest hospital is an hour away?
Yeah.
Then you're going. Yeah. So there's a lot of factors. But just, it was an interesting question that, like I said, he used to give this case to brand new paramedics doing their mega codes, and I'm like, that's not a fair case to give to a brand new baby paramedic.
It's good to see the thought processes though for people maintaining patient autonomy, considering your resources, considering your
all the different factors that come into play. All right, so ectopic, we talked about that. Life-threatening
and something you really can't fix.
Yeah, pre-hospital leave.
No. And you won't, now we do have ultrasound now
you can look for
our agencies. I suppose you can, but again, you can't fix it.
No.
You got to get them to the place where they can fix it.
That's right.
And this is something any ER doctor is trained and ready to handle.
Yeah.
So now if they're in, hemorrhagic shock, and they're pale and diaphoretic and altered.
All the signs of hemorrhagic
with all of this tenderness, distended abdomen. You got to go to the closest facility.
Yes. Closest facility with blood.
Yes, and a surgeon.
Yeah.
They got to get this thing out and fixed. So that's good.
So pre-hospital management, oxygen, IV, maybe some TXA if that's in your protocols. Yep. Maybe some pain management because these are pretty painful.
Yeah, but a lot of the opiates can really screw you over.
I was going to say, you got to be managing that. Ketamine.
Yep, ketamine might be good.
Yep, better option.
But you got to get them to a surgeon. You got to get that ectopic pregnancy out because, like you said earlier, it's a pregnancy that's developing where it shouldn't be. Right. And then that will be the ultimate fix.
Yes, right.
Now, there are some other antepartum emergencies outside of this version of hemorrhage, but the other ones we're going to talk about here are also hemorrhage emergencies. With an ectopic pregnancy, you're not going to be having the vaginal bleeding because you're bleeding, intra-abdominally. Right. But with abruption and with previa, these are associated with vaginal bleeding. Now, abruptio placentae or placental abruption is a painful vaginal bleeding, whereas placenta previa is a painless vaginal bleeding. Right. Both of them equally terrible. Both
just think abruption is pain, previa is no pain.
No pain.
Yeah, is the good way to. An abruption sounds so dramatic, though. An abruption.
It erupts like a volcano of blood.
Yes, which it
can really is. Yeah. We've had a number over the course of my career, a number of different times of vaginal bleeding causing a massive transfusion protocol. I mean, it's significant. I mean, woman, syncopal event from massive hemorrhage. Yeah. That's not benign. It's interesting the risk factor for these, both cocaine, and it's something worth. You hear a woman who's got vaginal bleeding, and you're just in conversation. You go through your normal history while you're transporting, right? And she's, I do use cocaine, right? That big red flag for these things. It really wreaks havoc with the placenta.
Smoking too, right?
Smoking, that's right.
Big risk, right?
And older pregnancies too. Right. Advanced age, 35 is the number. Pregnancies over 35.
We're not calling ladies over 35 old.
No, we are not.
Just to clarify.
Absolutely not.
No, we are just saying that there's some risks associated with having a pregnancy over the age of 35.
If you're a woman listening, whatever age you are, you're beautiful.
That's exactly right. Let's move on before we get ourselves in.
We're in trouble. There's no nice way or good way to ask a woman. Like, if you think she's pregnant, don't ask.
I thought you were going to say how old they are. I'm like, you just don't ask.
That too, right?
Yeah, and you do not assume that they're pregnant. Because even if they are, they're going to turn around and go, I'm not pregnant. You've never had them mess with you?
Oh, no.
You just think she maybe drinks a lot or something.
I have a dear friend who did that, the unthinkable. Asked when she was due, and she was just not pregnant at all. And how do you recover from that?
You don't. No. You just go bury your head in the sand.
And if you don't ask about the pregnancy,
then you're the risk reward benefit is not there.
Just don't say anything.
Just don't say anything until somebody else confirms it, and then be like, "Oh, that's great! I didn't know you were pregnant. You look amazing." You never
really suits you.
Man.
Right? Just don't even try.
No, the risk versus benefit is not there because the offensiveness will be 10 times worse than you not recognizing or knowing that she was pregnant. Yeah, don't do that.
Reminds me of that Michigan State story I've told you before in the elevator.
Oh, yeah.
There's just certain things you can't get them back. You just
toothpaste out of the tube, man. It's out there now.
It's just. There's nowhere to hide in an elevator. Oh my gosh.
Especially,
Anyway, so now we've gone to the antepartum, the before birth. Now we're in birth now, right? Is that what you said? During?
Before, during, and after.
During birth. Yeah, yes,
during
I
birth.
love that. This is the intrapartum emergency. So now we're given, we're delivering baby. Mm-hmm. So let's walk through the process of delivering a baby. Mm-hmm. So, hand on the head. Mm-hmm. A little bit of counter pressure.
Right.
Baby is usually facing down.
First off, I think we should say this, preface it with this.
Yeah.
Is that, again, like we said in Unit 1, Women have been having babies for thousands of years. It's a natural process.
I'm glad you said this.
Mom is going to be delivering the baby, right?
Yes.
You are hopefully just going to be like facilitating it, right? Making sure everything goes. But mom's doing all the work.
Yeah.
Right? These are just things that as the provider you can do to help facilitate the delivery.
Correct.
Right? You're not, mom's pushing, encourage mom, stay calm. If you're in this situation, I know you're going to be scared, especially if it's the first time you're going to be nervous, you're going to be scared. Stay calm because you want mom calm.
Yep.
So don't be freaking out. Act like you've done this a million times. Be a professional, and then follow these steps. But remember that this is a natural thing. If mom's full term, everything's probably going to be fine.
Yep. And then if you know what's going to happen and what's typically occurring, you can help to facilitate it, and you kind of guide things, knowing that as we'll get through this, we'll know where to hold and what direction to guide baby up and down.
Yes.
Rotations, to expect.
Yes.
And
what's
then,
normal, what's not normal.
Exactly.
Yes.
And then you'll also be able to identify certain emergencies you might be able to fix.
Yes.
One of the reasons why our life expectancy has gone up considerably in the last century is from maternal care. A large percentage of women and babies died, which really took the average life expectancy down. It's one of the major reasons it's come up. Yeah. And that was really one of the big reasons why in the Civil War era, the average life expectancy was about 44 years. A lot of people would live to be over 44, of course, but the average was brought down by a pretty significant maternal mortality rate.
Yes.
Now that
and musket shots decreased the life expectancy.
What's really interesting in prenatal care,
Here we go,
right?
Squirrel.
What's related to this is using gloves, which was actually a relatively recent discovery, which sounds ridiculous, but
imagine what we'll be doing in 100 years from now. We'll be going, those idiots back there.
And then using sterile scissors to cut the cord.
Yeah, don't take out your raptor shears. Don't do that.
And then recognizing some of these emergencies as being an emergency, to recognize it, to know, wow, if we want to have baby live here, we need to get a C-section. We need to get some surgical help.
Yes.
That hasn't always been available. So we really are in a unique position where we can identify some of the problems. Yeah. So let's walk through the delivery process. So now we got...
So mom's pushing. You're putting a little back pressure.
Yep. And
just especially if mom's been pregnant 5 times.
Well, let's back up a second, actually, and do this a little different. I think I would have taught the course differently if we would do it again.
Okay.
Chronologically, what problem could occur before you see the head? Well, what if you see a butt?
Yes, right.
What if you see a foot? What if you see a cord, right?
Yeah. Anything but a head is badness.
So we actually talked about this in the lecture, but I think this might be better time to talk about it.
Okay.
Because you want to elevate those presenting parts.
Yes.
I can't remember, phonic depression or something like that. I can't remember.
Yeah, I don't remember.
Whatever. But elevate the presenting part. And so women can get into that position where they're basically up on their knees, butt up in the air, and baby, now gravity, the weakest force known to man, can help pull baby down and put pressure off that presenting part. And hopefully...
Is this the...
I'm sorry, that was with the nuchal cord.
Yeah.
If it was a cord.
Yes.
Yeah, you're right.
Yes.
Sorry.
Which one's McRoberts?
The McRoberts is the one if you've got the shoulder dystocia.
That's right.
Yeah.
We'll get to that.
Yeah. But anyway, so you could have a presenting part, is my point.
Yes.
And you want to elevate the presenting part. And you can, by getting mom up in that position, you can alleviate.
And this is on her back.
This is on her back.
Yes, knees up to her chest.
Well, that's McRoberts.
That's right.
Sorry,
I'm getting them confused.
No, well, they are.
It's
confusing.
all tied together in my head.
So
that's right. That's
So the problem right now is we have something coming out of the vaginal canal that shouldn't be coming out.
Right.
Whether it's a head with a cord, or a foot, or a butt.
Yep.
If you're in the breech position, you do not want to deliver that thing. No. You want to coach mom on breathing. Don't push.
Yep.
Contractions are going to come. You can't stop that. Yep. But then you want to get mom in that position where she's got her butt up in the air, and then decreasing some of the pressure on that presenting part. And that especially with a nuchal cord, right? But anyway, so we got, let's say there's no presenting, there's a head that's crowning.
What we want to see.
What we want to see. Typically, baby's facing posterior, at least, right? It's looking towards mom's
facing
rectum.
Down.
Facing down. And gentle counter pressure on the head. And during the contractions, you see some progress being made. Now, one thing we'll learn later, and we can, I guess, mention it now, is that if during contractions the head is coming out, and then between contractions the head pops back in and disappears, that's turtling or whatever, that could be shoulder dystocia. And that might require you then to do that McRoberts maneuver to try to get that anterior shoulder that can get stuck under the pubic bone. But let's just say, like you said, most pregnancies, just guiding baby. So head is emerging. At some point, baby's going to rotate now, and now going to be facing one of mom's thighs one way or the other. And so we're going to keep our hands on either side of the head.
Just to support it.
Yep, just to support it. And then we're going to guide it. Now, when you're initially guiding it, you want to guide posteriorly first. So as the head emerges, I'm going to be gentle pressure posteriorly.
Which is going to deliver the anterior shoulder.
Exactly. And then once the anterior shoulder is clear, we're going to do a little bit of upward to get the posterior shoulder out. And at that point,
baby's coming.
Get ready. Baby's coming.
And a lot of fluid.
So
be ready.
So why don't you take us through the last part of the procedure now? Baby is in your arms. We're going to put it skin to skin with mom on her belly.
Well, first off, I'm going to kind of stimulate baby, right? We're also,
sorry.
Let's also not forget about delayed cord clamping.
We'll get there. Yes.
So, well, we're there.
Baby's
there. Out.
But while we're waiting, while we delay the cord clamping, we want to get baby on maternal skin as quick as possible.
But you can't
after you've stimulated, after you've
you can't lift baby up to mom. Because then all the blood you get after.
Oh, true.
Yeah. Just to be clear, I want to make sure everybody understands.
I see what you're saying.
Baby has been delivered. Umbilical cord is still attached to the placenta inside mom.
Yes.
Right?
Yes.
We want that good nutrient-rich blood from the placenta.
30 to 60 seconds.
Again.
Yes.
Yes. Literally count it off. Set a timer for 60 seconds. Let that good nutrient-rich blood flow into baby. Because if you pick baby up, again, gravity, if baby is higher than the placenta, now the blood is going to rush out of baby and go into the placenta. We don't want that.
Correct.
This can dramatically help you as the provider because it's better for your patient.
Yes.
So
as soon as the cord is clamped,
leave the baby down there for a minute. Right now, obviously, if baby's coming out and having extreme issues, and we need to handle that, then yes. But normal birth, leave baby down there for about 60 seconds, then clamp, cut the cord, and then.
I've been teaching 30 to 60 seconds.
I know in the hospital when I was going through nursing school, they literally had a timer.
For 60 seconds?
Yep. They literally timed it. The moment baby came out, hang on. I remember it was actually kind of funny. I think I told this in the lecture, but we were watching a lady give birth. And it was this old school OB. I mean, this guy's probably been delivering babies for 30 years.
Right.
And that baby came out, and he was just doing what he's done thousands upon. And he goes to pick the baby up, and he's going to clamp, cut. And the nurse is like, no, Dr. Axene, we need to remember delayed cord. Oh, that's right. And he sits there, and he just held the baby. And 60 seconds, and they started a timer. So if you're doing it.
I almost did the same thing.
Well, I mean, in the heat of the moment, you just. But I think if you're doing it 30 to 60 seconds, it's nothing mandatory or magical about 60 seconds. As long as you're not just immediately cutting it, that's the key.
Yes, or clamping it.
Clamping, yes.
So when you clamp the cord, it's 10 centimeters from the umbilical, the umbilicus, and then 5 centimeters from that.
And cut between. Don't go clamp. Yeah. Common joke. And then stimulate baby. You want to kind of. I look at it like piss baby off.
And dry baby.
You're not going to break baby. Baby's bones are like rubber. You're not going to break baby.
And most of the time, everything's going to go fine.
That's
Stimulate, baby's crying. And then
they're going to be a little bit blue. You're not going to have an APGAR score of 10 at 1 minute. That's not a thing.
They never do that.
They never do that. And if you say that, everybody's going to know you're stupid. So don't say that. We literally had a call with some midwives where they had documented that the APGAR score was 10 and 10. And I'm like, that immediately just discredits you. It's like saying their heart rate's 70 and their blood pressure is going 20 over 80. Like, no, it wasn't.
It's not quite as bad as a GCS of 1.
Or 0.
That's worse.
Yeah. So, but again, your APGAR score, they're going to come out. They're going to be a little bit blue, usually in the extremities. That's normal.
We forgot a step. Something that we should do when we're delivering baby. As we were delivering as the baby rotated and the head emergence, you got to sweep the neck just to make sure you don't have the nuchal cord.
And wash, like you can kind of wipe off mouth, but we don't suction mouth and nose anymore. Remember, we don't do that.
That's right. Yes, not routine anymore.
Yes, if you see some meconium or some signs.
No, not even with meconium.
Oh, okay.
Yeah, not even with meconium. I'm sorry. That's a new thing.
I was going to say.
We used to do that. Now, follow your protocols, but
right.
But not anymore. Not
well, we
routine
used to automatically suction every time.
We did, I know.
Yes, but then it switched to, you just wipe, but then I still thought if there was meconium, you would want to suction. So they took
last I read, not even with meconium. The only time we would suction, it's just not suction routinely anymore. But if after baby's delivered, there's any sort of respiratory issue or distress, suction, obviously, right away. Yeah. But even with meconium, not routine suctioning, based on what I read.
And it's a vagal thing, right? Wasn't it the suctioning was going to stimulate?
I don't know. That's a good question. I should do some more reading on that. I don't, but not routine anymore. That's a good point. Yeah. So we've delivered baby now. Yeah. Now let's talk about some situations you may encounter. The nuchal cord, obviously. Oh, yeah. Usually if you do see a nuchal cord, it's loose and you can gently pull it around baby's head, and everything's fine. You just continue with what we talked about. Right. But if it's tight and impeding delivery, you may need to cut it or continue to try to deliver.
Clamp it first.
Yes. And actually what they recommend is to try to deliver that anterior shoulder first. But
you might not be able to. If it's that tight, it could be giving them back pressure like you talked about with the turtle.
That's exactly right. Yeah. So this could be a bad situation. And this is, unfortunately, it's the reality of pregnancy. The delivery process can be dangerous. And hopefully you're almost to the facility at this point.
And the good thing is these are kind of rare. This is super common.
But you can cut that cord or attempt to cut that cord or, if you have to. That's a tough situation. Yeah. But usually if you do encounter a nuchal cord, it's going to be something that you can loosely pull around.
Pop it around.
Now in delivery too, we talked about the presenting part, like if you're in breech position, you're going to coach mom, like we talked about, just to breathe. Don't push during contractions until they get to the facility. They're probably going to need a C-section. Yep. Let's see, what else have we missed? No, I think that's
all for antepartum.
I think the antepartum stuff. Yeah, that's it. So the key there. I think the other concern would be with breech delivery is shoulder dystocia. We mentioned that. That's the turtling thing. That's the other major kind of problem that you could encounter. We had shoulder dystocia issues with my son. He had trouble in the birth canal with my wife.
Huge Axene shoulders.
And a big head and all that. Yeah. But we, anyway, and McRoberts is that maneuver we talked about where the knees, up into the chest can help to.
Little pressure on the pubis.
Exactly.
Pop that shoulder.
Then pop it through, and then you continue as we talked about. So, all right, that's the shoulder dystocia, which is kind of a unique thing. In the last period now, the postpartum. Now baby's out. You've cut the cord, you clamp the cord. Baby's hopefully going to be on skin to skin with mom.
Yep.
But one of the big issues, which is very common, is uterine atony. Postpartum
squishy uterus.
Yeah, squishy uterus. Yeah. So what do we do to fix that?
Massages the fundus.
Yeah, and aggressively.
Yes, you do. It's not a soft.
It's not like you're petting the table.
Guys, this is the one time where you want to be
aggressive.
Yeah, fairly aggressive. I also heard, and if I remember correctly, if memory serves from nursing school 6 years ago, breastfeeding can help mom with bleeding. She's having some postpartum hemorrhage, correct?
That's right. It stimulates oxytocin release from the posterior pituitary.
Yep.
That's absolutely
right.
So
if you've got an issue with mom bleeding, maybe if it's baby feeding,
while you massage.
While you're massaging, it could be a natural way, right?
Yep.
To help some bleeding control.
Now, in our department, we have Pitocin, which is an analog of oxytocin, what the body makes, and we can give that to hasten the contraction of the uterus. Well, that's really what it is, right? It's contraction of the uterus that
Yep.
helps to decrease the postpartum bleeding. Postpartum bleeding is pretty normal.
Yeah, a little bit.
Yeah.
Yeah.
Now, if you part of the process too is delivering the placenta, and if you've got placenta in there, you're going to have trouble getting it to relax. You got to get everything out.
Yep,
So,
yep.
and that may require something from the OB doctor in the operating room to get,
it
remnants out if we
Yep,
need,
yep.
if we need to. But you won't be able to do that in the.
But yeah, make sure that you know, like dudes out there that aren't paying attention, there's going to be two things coming out, the baby and the placenta. So after you've delivered the baby, there's something else that's going to come out after that. So be ready for it.
And then
it's important to tell the doctors if that hasn't come out when you show up
that's
at the ER, like, hey, the placenta hasn't come out yet. So
that's good.
Yeah.
But the bleeding, the third thing that's coming, all that blood, is really, it can be life-threatening. Postpartum hemorrhage is no joke.
No.
And it's something that we have to, just like we talked about before, with placental abruption and previa and all those, is recognizing the signs of hemorrhagic shock.
Yes.
It's kind of one of those, this is something we have to be good at. It's so many, whether it's a shark bite, a motor vehicle accident, a
Shark bite should be pretty obvious. But.
Yeah, that's true. But it's all the same pathophysiology.
Yes.
We're bleeding from somewhere. We have to stop the bleeding.
Yes.
If you're bleeding in your belly, it's really hard to stop that. You got to get in surgery potentially. So but with uterine atony or postpartum hemorrhage, if you have Pitocin, give it. Otherwise, massage. Maybe have the mom breastfeed. Those things can all help to decrease the risk of uterine atony. And even if that uterus feels really firm when you're palpating it, the lower half, which is under the pelvis, can be
super spongy,
really spongy, or boggy. I think I like to use boggy.
That's probably a better word.
Spongy's good. Boggy, spongy. But anyway, and you can have that postpartum hemorrhage, even though the uterus feels. Just keep massaging.
Yeah, it's not going to hurt
going.
anything to massage it.
Yeah, so that's really important. The other major postpartum issue, which is the last one we'll talk about, is neonatal resuscitation.
The worst one.
And it's kind of like delivery. Most of the time, when you have a delivery, baby's going to be fine after you stimulate. They're going to be crying. They turn pink, and they're breastfeeding, and
everything's good.
And you arrive to the ER, and everybody's singing "Happy Birthday."
That's right. But occasionally,
and occasionally it's not. But you know what's really cool for us? Let's simplify this, Matt. 99% of the time when you do have an emergency, it's related to respiratory. It's related to those alveoli collapse because of a lack of surfactant that decreases the surface tension so they can open up. So most of the time this isn't going to happen. You stimulate, baby cries, and everything's fine. Every now and then you're going to see some respiratory issues and maybe a little bit of cyanosis, and you're a little bit scared. That stimulation's going to be okay.
Yes.
But a little bit of positive pressure ventilation, non-invasive positive pressure ventilation, if you need it, is going to open up those alveolar sacs, and it's going to get baby back to where it needs to be. And most of the biggest risk factor for these postpartum neonatal emergencies is preterm. And we've talked about this in our lectures, but it's pretty simple actually. It's all usually related to respiratory.
And we don't get endorsed by any companies, but when we find something that works,
please talk about this.
The NeoTees. If you've never heard of a NeoTee, NeoTee, it is an amazing little tool for these exact kind of calls. You've got a neonate you just delivered, they're having problems oxygenating, the alveoli won't open up. It's an amazing little tool. You can set your PIP, your PEEP. You don't have to have a ventilator. You hook it up to an oxygen bottle, and then you can sit there and put your finger. It's an amazing positive pressure tool for these situations. So look into that. I mean, they're not expensive. It's a great tool to have in your toolbox. Very useful. And for this exact case.
Yes.
Right, but yeah, neonatal resuscitation, respiratory, you got to start bagging. And then we have some criteria on heart rate as far as when we do what.
Yeah, and the other thing I would mention too is that oxygen saturations are pretty wonky.
Yeah, that's going to take some time. Look at your baby. If your baby's blue, then
you're going to get freaked out if you look at the numbers.
Yes.
I'm talking 60s.
Yes,
I mean, initially, right? Yes. Eventually, after about 10
time.
Minutes, you're going to be a pseudo-normal.
They're literally oxygenating for the first time ever.
Yes.
So give it a minute.
Yeah, that's right.
So look at their color. If they're really blue, you need to be oxygenating. You know, if they have some extremities, that's kind of normal, but still.
Yeah.
If they look like they're struggling, and then look at the heart rate, then we need to be doing more.
Now, and again, like we talked about, 99% of deliveries are going to be fine. And of that minority of times, 99% of those are going to be respiratory.
Right. So we're talking a very small percentage.
Very small beyond that, where it could be cardiac. And actually, that's you want to consider even a neonatal, cardiac monitoring, maybe even an EKG. But this is, depending upon how long your transport times are, these are the rare things.
And I would say probably most, unless we got critical care flight folks that have equipment like that. Most of your EMS fire department agencies aren't going to have that.
And what these are usually related to is cardiac anomalies,
Right.
things that
There's no way you're
99% of the time, when it doesn't go right, it's respiratory, and you can do certain things to help with that, even if it's intubation.
That's right.
Right? Neonatal intubation, like we practiced together on that tiny little baby, remember?
Tiny, yep, up at the cones.
But when you're getting to there's a subset of patients with congenital cardiac anomalies.
Right.
And some of these are all they need is a medication to keep that ductus arteriosus open, and that
I always think of when I took critical care. They said it was like Harry Potter, ductus arteriosus.
Yes. Okay. Yeah.
Anyway,
well, that's a key though, and I think the vast majority of these emergencies that are freaking you out are respiratory, and we have a lot that we can do.
right,
Otherwise,
UVCs. If you have the ability to use UVCs, if you need to give meds and stuff, you can do that.
oh yeah, that's right. Yeah, UVC. We didn't talk about that.
Yeah, you got two arteries, one vein. So the big, it looks like a smiley face. The big hole is what you want to aim for if you're doing a UVC catheterization. So it's not really difficult.
So let's, I guess, summarize. We've had 2 hours of content. The first hour we hit kind of general considerations of emergencies a pregnant woman might be in, and things that we need to think about with their anatomy and physiology.
Yep. Vital sign ranges, common problems.
Trauma and sepsis, things that require a different mindset when you're treating them, right?
Yeah.
So that was good. And then the second hour, we got into some of the birth-related before birth, during, and after birth. The one thing I would like to reinforce would be before pregnancy. Remember that in an ectopic pregnancy, any woman of reproductive age, like we said, who's got abdominal pain, you've got to think about a possible ectopic pregnancy.
That's your most serious concern.
Yeah. And then in the postpartum period, the thing that I would remind you of is that woman's body is still in that pregnancy physiology. And there are some emergencies like preeclampsia that can occur 6 weeks after the baby's been delivered.
That's right.
So you've got to still think about some of these pregnancy-related emergencies. So those would be the two things I would say. Early on, mom doesn't even know she's pregnant, but she's got an ectopic, right? And then later on, postpartum, you can still have pregnancy emergencies. So it's something to think about.
Yep. Yeah, again, these are calls that, if you listen to podcasts, do your studying, because they're, low frequency, you'll be prepared to handle kind of any situation that comes along. But again, the comforting thing is that very small majority of these calls are going to be something seriously wrong with mom or baby. We have to be ready for them, right? But most of the time, if you're going on a run-of-the-mill LB call and mom's at, almost full, just everything's going to be fine. Calm down, relax. And
I think that's a good way what you just said is a great way to approach it. It's like, this is probably going to be fine. But we know that we obviously hope for the best, but we've prepared for the worst.
That's right. We know what to do. If something's wrong with mom, we know what to do. If something's wrong with baby, we know what to do. It's all about preparation. Right?
Awesome. Yeah, preparation and practice. And then hopefully with these assessment questions, if you're doing this for CE, you'll take them and
take your assessment questions. If not, we'll see you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.